Hello everyone. My name is Shane. The name of my presentation, along with my colleague Joseph, is Urban-Rural Disability Disparities Among Older Adults in Middle-Income Countries. So as you might know, the world is rapidly aging and also rapidly urbanizing. Both in the early 21st century, we saw the proportion of older adults surpass the proportion of children across the world. And at the same time, or around the same time, I should say, the urban population proportionally surpassed the rural population. And so both of these phenomena have worked together to ultimately impact older adults, specifically in that infrastructure is developed in urban areas. And in rural areas, there's been extensive outmigration from working age adults who would possibly be otherwise be caring for older adults. And so global aging and urbanization have worked together to create these unique economic and social arrangements that will affect the lives of older adults. Disability is integral to this because people oftentimes age into disability. The disablement process argues that various social and environmental influences, individual structural factors, are push and pull indicators of one developing disability across the life course. And in urban versus rural localities, those social, environmental, and cultural influences may vary. Now, the literature on older adult disability and looking at urban-rural disparities oftentimes find that rural dwelling individuals report higher rates of disability. However, there is some literature, particularly from Bangladesh and South Africa, that argues quite the opposite, that there's a higher rate in urban localities. And this concept is pertinent to the concept of aging in place, which is attachment one has to their home and their community, which may vary given on urban and rural contexts. The aim of our study is to investigate urban-rural disparities in activities of daily living disability in rapidly aging and urbanizing middle-income countries. Now we choose the HRS International Family of Studies for this particular analysis. We choose the 2018 data because that is the most recent year that LACI was fielded a survey data, and therefore we chose the 2018 data from Mexico and China as well. So we're looking at 3 countries, and our independent variable is place, which we define the reference group as urban and the focal group as rural. Our dependent variable is a harmonized variable, a dichotomized variable, that is, looking at reports of any activity of daily living disability, as we see here: bathing, bed transferring, dressing, eating, or toileting. And for our adjusted logistic regression analyses, we have country-specific regressions, and each of them have a 5-model buildup where we control for gender, education, comorbidities, family ties, which we have as 3 variables, and then institutional supports, which we have 2 additional variables listed here. So for our sample characteristics, we have highlighted in yellow some just notable observations. On the far top right, we see in China, before we control for age or anything, we see that rates of disability are particularly high among rural respondents. And down at the bottom right, living near a child is particularly less common in China. Looking at the center here in India, we see that comorbidities are particularly lower in India overall, but household sizes are comparably larger in India, and having a public health insurance plan is less common in India. And then in the bottom left here, we see that the distinction between urban and rural respondents reporting a pension, that disparity is quite large in Mexico. And so for our country-specific adjusted regression analyses, we're looking at Mexico here. And ultimately what we see when we control for age and gender is that there is a small significant difference, but a difference nonetheless, with rural respondents reporting more disability. Now, when we control for education, and I'd like to add here that education is looking at less than upper secondary versus upper secondary and tertiary education. This is a harmonized variable. And when we control for this particular variable, we don't observe a disability difference anymore. But then once we control for comorbidities and family ties, we do see a disability difference among those rural respondents. And then once again, when controlling for institutional supports, meaning public health insurance and pension, we no longer observe a difference. And we'd like to note here that having public health insurance in Model 5 was associated with a higher reports of disability. Now for India, the results are a little different here. Once controlling for age and gender in Model 1, we see that there still is no difference between urban and rural respondents. But once controlling for education, there is a pronounced significant difference in place difference in reports of disability. But once we control for comorbidities, which is a count variable of 6 comorbidities, we see that there is no longer an urban disadvantage. And because we are interested in, well, what does comorbidities even mean, the variations, we actually did a supplemental analysis where in Model 3, we actually have a binary variable for each of the individual comorbidities, or morbidities, I should say, and hypertension by itself explains this difference without incorporation of the other 5 morbidities. And then family ties and institutional supports subsequently do not contribute to any significance. And then finally, for our regression analysis from China, controlling across these 5 models, we consistently observe a rural disadvantage, and our covariates don't do much help to explain why we might observe a rural disadvantage. And so for our discussion, we'd like to note that there is a rural disadvantage, an ADL disability in Mexico and China. And particularly for Mexico, we found that tertiary education is protective of ADL disability, while upper secondary was not. And then, as I mentioned earlier, when we controlled for institutional supports, which helped explain that small significant difference, it was actually there was a very strong effect of public health insurance having a positive association with disability. And that is something that is not commonly observed in the literature. As for India, we observed an urban disadvantage, and there's been previous research on different disabilities in India that observed quite the opposite, a rural disadvantage. But as I mentioned earlier, comorbidities as more of a general concept doesn't give us much information, but hypertension by itself does explain this difference. And also diabetes, I should mention, had a partial explanation as a binary variable in a supplemental model. And so we speculate from this that perhaps there might be underdetection of comorbidities in rural areas. And then as for China, we did not observe, we observed a rural disadvantage, but we didn't observe any notable covariate distinctions of why this disadvantage might occur. But we do, from existing literature on cognitive disability, we speculate that the Hukou system that particularly disadvantages rural dwelling individuals might have something to do with explaining why this disadvantage occurs among rural respondents. And now there are, of course, limitations to this study, and it's largely in incorporation of different variables and that we're trying to harmonize these 3 countries. Occupation is a question that is asked in many of the HRS family of studies, but there's a lot of missingness. And it would compromise our sample size if we were to include such a variable. Also, there is no peri-urban or peri-rural distinction. It's just urban and rural. And of course, that living spaces might be a little more complicated in terms of what distinguishes them as urban, rural, or somewhere in between. And then there was no assistive device that we could account for. Much of the sensory disability literature, there's a large emphasis on, did you control for glasses? Did you control for hearing aid usage? But in the physical disability world, we don't really stress the importance of maybe cane or wheelchair usage. And so it would have been helpful to have such a variable. And then also the harmonized education variable is both a blessing and a curse. It is very helpful that we can compare middle and high income countries, for that matter, with this particular variable. However, given that the reference group is less than upper secondary education, we can't look at those unique differences among the less educated groups, particularly those that have no formal education, which literature suggests have particularly high rates of disability and other health conditions. And so we conclude from these findings that place disadvantage is heterogeneous and that rural disability disadvantage might not be as consistent as we might believe, and that there are various factors that explain these place differences, as we observed with comorbidities in India and education and institutional supports in Mexico. And we conclude from these findings that in particularly rural localities, that improving education, particularly upper secondary education, and improving healthcare access might bridge these urban-rural disparities in older adult disability. These are our acknowledgements, and that is all. Thank you.